My work with the fourth year program at the University of Toronto is quite interesting because I have a student that comes to Windsor for 2 months of the year after she does all her academic side, and she has to, he or she has to learn how it happens and how it works. So I've got a little different process, and I actually gave one of my students a presentation to do on Parkinson's and laid it out for her, and she was presenting to nurses in a long-term care facility. That's what the LTC is, because I do all my work in nursing homes, it seems. She did a very good job, but part of the group she presented to was patients with Parkinson degrees, and there was a number of nurses present. She got partway through her presentations, and one of the patients slowly put up his hand, and he said, "That's nice, but slow down." And I thought that was amazing. That was the total presentation. Every nurse in that room got the message. My student got the message, slow down. So if I don't speak slow enough or loudly enough or I'm not coming across, please let me know. Because we have to just slow down to enjoy life and keep pace with Parkinson's disease, and I think we do much better. So that was the biggest message for that student. It was quite interesting. She hasn't forgotten that presentation, and she did very well with it. Okay, they're telling me to slow down and speak up, so thank you. So, my job, I guess, is to go through Parkinson's disease and talk about the drugs, and I think when I talk polypharmacy, I've seen a lot of problems related to multiple drug use, and what I usually don't see is a single problem in a patient. So I don't have a patient with just Parkinson's disease. In fact, in the long-term care facilities, it's usually many disease conditions. So you might have 8 to 10 medical conditions going on and 16 to 20 medications to treat those medical conditions. Parkinson's alone, and I was just looking at patients we have at our pharmacy right now, I would say average around 15 medications apiece. Is that appropriate or inappropriate? And at this time, I feel it's appropriate. But I think we have to make sure that the timing and how we take those medications is done right in order to reduce risks in those patients. And it comes across day after day, and that's what I teach the students. That's how I deal with the medical students as well. And I don't think there's any doctors left in this room, but I always remember my daughter who was writing her fourth year exams for medicine, and she turned around and said, she calls me from Ottawa, and she says, "Dad, you've got 5 minutes. Tell me everything you know about pharmacology." And I says, "It's worth 1% of your final exam, so don't bother." And that was everything I could tell her about pharmacology. So there is a difference between pharmacy and medicine. They deal with dynamic effect, and we deal with what we call kinetic effect. And how in other words, they're dealing with what the medication does to the body, and we're dealing with what the body does to the medication. So I think we have to work together, and you have to keep pharmacists around. So I'll get off that bandstand. Just to go through a little bit about Parkinson's, we always talk about it's a chronic progressive neurological disorder. It affects dopamine and acetylcholine. You heard the other speakers talking about monoamines. Monoamines are those transmitters that allow nerves to talk to each other. Our nerves are not like telephone lines that are connected. It's more like the internet, where there's a disconnect and we receive signals. And if there's a breakdown in the signal or it's a slow process, we're not receiving it at the same rate or appropriately, so we may miss out on a number of information. So the information transfer isn't there. We always talk about dopamine, which is the neurotransmitter that's affected by, that affects movement in Parkinson's. But we have to think about the other neurotransmitters that are associated with it, and that's acetylcholine. Dopamine, we think movement, but all psychiatric disorders have their mainstay in dopamine. Every drug that improves, I'll say every drug or food that gives us a state of awe affects dopamine. Smoking, so nicotine, caffeine, will increase dopamine levels. okay? Any drug, there is a nicotine pathway, which it causes a sense of awe and increases dopamine. So anything that increases dopamine may have an effect on Parkinson's. Because Parkinson's is too little dopamine. Psychiatric disorder is too much dopamine. So what's the side effect of Parkinson's medication is psychosis. So too much is no good, not enough and you're frozen. So where do we go? But everything is in balance. So what happens when dopamine drops? The other neurotransmitter involved here is acetylcholine. Acetylcholine is associated with memory. We talk about our memory drugs. We give anticholinergic medications for nausea, vomiting, for bladder discomfort, and they affect our memory, reduce our memory. So acetylcholine or cholinergic response increases our memory. And that's where Aricept or Exelon, those type of memory aids come from. If my levels of dopamine drop, my levels of acetylcholine go up. What happens with too much acetylcholine? Cholinergic response is shaking, tremor, part of our association with Parkinson's disease. So it's a balance, and we try to maintain a balance, and we use different medications to do that. So it's all part of the same process. I like the last line as far as Parkinson's, and that's a complex condition with neuropsychiatric involvement and other non-motor manifestations. And I think that's a clearer picture of what Parkinson's disease is today. It's not just a slow disorder. It affects everything that we do. Okay? And the non-motor manifestations are the things that we tend to treat the most at this time. So we all have this data, basically 100,000 patients in Canada, and you're looking at almost $5 billion to treat the condition. And that's right to hospital, but lost time at work and everything else. And the age of onset, they say average age of onset is 50, but we know people in their 20s and 30s do acquire Parkinson's. I treat mostly elderly patients. Many of my Parkinson's patients are in the long-term care homes or nursing and retirement homes, are actually younger in those homes because the average age of patients in the homes is 82, and they're in their 70s and sometimes 60s. So it may mean earlier admission to long-term care because of the motor and non-motor symptoms or the psychiatric symptoms of the disorder. So it is a problem. We're seeing it every day there. And what we find is that those percentage of people where you get an earlier onset of disease, it seems to be progressing much quicker, which may suggest that this is two different entities. One might be a wearing out in the elderly, and one might be a true Parkinson's, but nobody's decided yet. My reading hasn't gotten there yet either. So what are we dealing with? It's basically when we're talking about neurons. Neurons there's some neurons in the brain that produce dopamine, and as we get older, those neurons are declining. In Parkinson's disease, and the big thing here is 70 to 80% loss in nerve transmission of dopamine occurs before we have clinical presentation of the disease. So the damage is done. What are we going to do to protect ourselves? I love the previous speaker when he says REM sleep disorder may be an early symptom. Another early symptom might be olfactory or loss of a sense of smell. People, that you're talking to, or if the message gets out, if there's anything that suggests this is an early sign of Parkinson's disease, that's when neuroprotection may come into effect, even though we don't have a lot of agents in that area. But anything that maintains dopamine may slow progression. So there's some interest that has to be looked at as how can we diagnose these people earlier so we can better treat those people that are involved. So it's quite interesting that way. So early disease, when you're looking at symptomatology, we're talking tremor, and as I say, tremor is usually that resting tremor. When you're purposeful movement, so these people can eat. Whereas a person with essential tremor will find as they're trying to eat, they're shaking more and they can't eat. Two different disorders. Okay, tremor responds primarily to anticholinergic agents, but it does respond to dopamine a little bit as well, because if I raise the level of dopamine, I reduce the acetylcholine response. So I get some benefit from using dopamine agents in order to reduce tremor. The primary problem we see is in the rigidity, and that's where they say the cogwheeling and the stiffness occurs. And this is what really causes a lot of the discomfort as far as Parkinson's, and it's the one that responds best to dopamine therapy. Akinesia or lack of movement, and that's the facial mask, and people walk and their arms don't swing. Or what we mostly respond to is, or what we suggest is the bradykinesia, which is the slowness of movement. It's not just visual slowness, but our whole body inside is slow as well. There's almost an antsiness that's going on within the body when you're feeling this. Postural instability is one of the symptoms that does not respond, and that's sudden drops in blood pressure. Sometimes we see a lot of low salt in our body as well. You'll see blood work coming back and your salt levels are low, or you stand up and your blood pressure drops. Things like that result in the instability, and that leads to a lot of falls and problems, especially in those patients that I see. We all hear the stories about people getting up at night and falling on their way to the bathroom. That's the most common time of falling, and a lot of that could be related to type of medications that we're taking at nighttime as well, so we try to reduce that. Fall risk is huge in long-term care, but I see it commonly. Presently, I'm taking care of two neighbors, and it's weekly I'm getting a call that one of them has fallen or something has happened, and I've tried to modify a number of things. We finally got CCAC in to work with them. But postural instability does not respond to dopaminergic therapy. In fact, it gets worse because of the medications. Medications will induce falls as well. So we have to keep a balance of everything that we're doing here. Dysphagia is more of an end-stage problem. Some of the things that you will see as changes in the writing. My joke is many of my doctors write this way anyway, and it's so small I can't read it, so please help me. And actually in changing the speech. A slow, low volume speech is something that goes on, so it's stopping and listening. I do have a problem. I get a little hearing problem, so I have to turn around and get a little closer as well. So those are things that are commonly seen. Advanced disease, mostly related to dopamine therapy, and seen with levodopa, not seen with other dopaminergic agents because of the relative potency of levodopa. Most patients will go to levodopa, but this is where we call the dyskinesias, the on-off fluctuations, the freezing, the wearing off phenomena, and we'll discuss that further on. Non-motor symptoms, and there's a whole slew of them here. We talk, constipation is a problem, falls, orthostatic changes, bladder dysfunction, erectile dysfunction. I think I've treated that for the last 20 years in my patients, and I'm seeing a lot of prostate cancer, or a lot of Parkinson's patients coming in. Depression, as we said, is very common, sleep disturbances, psychoses, dementia. Some people actually worry that some of the dementia is related to the slowness. They're not quick at responding, and therefore we